Hey guys, what's up?
I'll let you introduce these. I know this one in
Yes.
the middle, and I know that one back there. You look like somebody I would know about. I'll let you guys introduce yourself.
Yeah,
Glad you're
sure.
here again, Stephen. We can learn a lot. This was great last time, so thank you.
Thank you.
And so I'll let him kind of cover everything today. If you have any questions, again, we'll have about an hour, and then we'll wrap up. Just be respectful of their time. They may have to get out of here. I know sometimes we like to bombard our guest speakers with questions, so let's just be respectful of that. But thank you guys for coming.
What time do we have to be
Appreciate it.
back? Like 1:30?
And then just if you don't remember, Karen and Casey graduated their first year class. Right? And we appreciate people like Stephen that are willing to hire them, that are willing to come in. He actually met them in a little round robin, little 5-minute speed interview session we did for the group. And so he was really impressive to them. And obviously, I hope they were him. Hope you're still here, I guess, right?
They're loving it.
Yeah.
They're loving it.
All right, I'll let you have it. Go.
We'll kick it off. First of all, I am way over caffeinated, so if I'm talking too fast or if you have any questions, feel free to just stop me in my tracks. So, Steve Fort with ACE Physical Therapy and Wellness. I wear another hat, and that is teaching internationally and then in the United States with GEM. So, I'm one of the two guys that started GEM, and we teach a lot. It's a lot of fun. Very passionate about it. Today we have Karen Carmona with us. Hello. So Karen's PTA from y'all's program. She works alongside Arva, who is my business partner in mostly a pelvic floor setting. So if you guys are interested in that, you can definitely talk to her, potentially get into some like clinical rotations if that's in the cards and stuff like that. So she's a good connection for that. You guys know Casey Nicholson in the back. So Casey's more on the ortho sports side. She's really cool because she's also a CrossFit coach. So I love sending my guys to her that need to be trained in like proper deadlifts and squats. And if a patient needs their butt kicked, usually I'm like, all right, Casey, this one's yours. I expect to see them crawling out of here sweating and crying. So, and then this is Marcella Farias. So Marcella is actually a PT that's trained in Brazil, and she's working on getting certified in the US. It's a long, lengthy process. Anybody that's international, it's quite way too long of a process to be able to practice in the US. So you guys have to give her props for like putting herself through that. In the meantime, she's a tech with us. So we took her on as a tech, so she's able to continue to grow her experience and work with patients and stuff like that. So today is a little bit different. We're doing a pelvic floor lecture. I do not participate at all. All right. I have worked with many pelvic floor therapists and PTAs. I don't see pelvic floor patients unless I'm seeing them to loosen up their backs or SI joints or get them going with like more sporty functional stuff. Okay. But when I was in PT school, we had a short lecture on pelvic floor. And I think the function of this is just to get you guys aware, because whether you're interested in pelvic floor or not, I promise you, you'll have patients that will benefit from pelvic floor physical therapy. And so you need to know a little bit about it, enough about it that you can help yourself, help a loved one, or help a patient get to the right place and be able to have a intelligent clinical conversation with somebody if and when that's needed. So here we go. There's us, Gem and Ace, Ace and Gem. You guys can connect with us. If you connect with us in any way, shape, or form, I can get you like socials, website, and stuff like that if y'all are interested. We've got some great free videos at Gem Physio and at Gem Physio-2025. The Dash 2025 is more of our USA branch. The other one's kind of more of a general international. I've kind of selected stuff specifically for the USA side of things. Announcement, we're going to be doing an in-person dry needling course just down the street. And usually, so when I took a dry needling course, it was through Kineticore and it was about $1,250. We're running it for students, PT and PTA students. The price is like $350. So if you're looking to get pelvic floor certified either this year, we'll do another one next year, you're more than welcome to drop in. I actually brought a sign-up sheet that I'll have here on the way out if you guys are interested, or you can reach out to us at a later time. I don't know if the timing will be convenient for you guys or not. It's November 15th and 16th, Saturday and Sunday, 8 to 5. Body's a map if you know how to read it. Learn how to read it. Today we're going to be talking about pelvic floor. Okay. So I want to give you guys a really short overview, and then hopefully we're going to see some really cool, like practical stuff, okay? So let's try to get through. I'm going to really just skim over this stuff. I did send pelvic floor vocabulary and kind of an outline of today's lecture to Michelle and Michael, to Dr. Valencia and Dr. Cox, so they can get those to you guys if you want to go back and reference anything we talk about today. Okay, so my business partner, Arva, who's a pelvic floor PT, she said if she could tell you one thing about pelvic floor, it's that Kegels don't fix everything. And this is hopefully going to offend nobody or nobody's family member, but if you go see a male OBGYN and you have pelvic floor issues, they will tell you, do Kegels, and that's the end of the conversation. Or at least for the last 20, 30 years, that's what it's been, right? It's not always appropriate. We're going to get into a little bit of why. All right? Anatomy, hopefully you guys' anatomy is pretty decent for the pelvic bones. The ligaments, not too worried about that right now, although they're all very interesting and they do have pain referral patterns. There's 3 layers of pelvic floor muscles. This is layer 1. As fun as it is to say all the names of these muscles, we're not going to do that. So there's layer 1. Notice how they're all connected to the different canals and cavities. Okay. There's layer 2. And then layer 3, the most superficial layer. And what's interesting about these layers is that in any of these muscles, you could have one or more that are hypertonic, like tense, right? So we got 2 sides of pelvic floor, right? You can have one side that's tight and one side that's inhibited. You can have 2 sides that are hypertonic, or you can have 2 sides that are stretched out or inhibited, right? Like maybe after someone's had a baby. And so the reason Kegels is not the answer for everybody is because, first of all, we don't even know if that person's doing it right. But second of all, you can have one or both sides that are hypertonic, and you're just feeding a problem. So pelvic floor patients can't be given a book, and they can't be told what to do. They have to be seen. They need to be evaluated, have an internal exam by a physical therapist, and maybe some internal work by a PT or a PTA. Someone's just recently been getting her hands dirty. Okay, so the pelvic floor has a lot of functions. Some you might know, some of them you might not know. Okay, this is what normal anatomy should look like with good, healthy pelvic floor support. I want you to recognize these different organs and orifices, canals, whatever. And just so you know, any of these can fall into the pelvic floor or fall out of the pelvic floor, right? So we'll take a look at some of those, okay? Before we do, real quick, a proper pelvic floor contraction is a lift, okay? If you Valsalva and you hold your breath and press down, then pelvic floor is actually getting pushed away from you. And that's one of the many things that as pelvic floor therapists, we cannot have people doing Valsalva, even on the sports and ortho side, even in the hospital, even on the neuro side. Once in a blue moon, if we're truly desperate, we will use a patient's Valsalva for stability, but they have to be really bad off for us to be going after Valsalva for stability for like a really weak or neuro patient or something like that. Okay, so pelvic floor dysfunctions, incontinence, right? More common among females that have had a baby, but anybody can have incontinence. Stress incontinence, if you sneeze or exert yourself, pee's coming out. Urge incontinence, you feel like you need to go and you can't hold it long enough to get to the bathroom, right? You feel it and you pee, right? Mixed incontinence is maybe a combination of the two. Other pelvic floor disorders, we can have fecal incontinence. We can have pelvic organ prolapse. So we're going to look at the different versions of that. We can have pelvic pain syndromes, diastasis recti, and endometriosis. So here's the different types of prolapse that we can have. Cystocele is where your bladder comes down. Rectocele is when part of your large intestine at the very end is protruding into the pelvic floor or past it. The uterus or cervix, you can have a uterine prolapse. There's different grades of that. There's different interventions for that, medical and therapy-wise. And you can have an enterocele where your small intestine is herniated through as well, okay? Diastasis recti takes many shapes and forms. Has anyone ever felt a diastasis recti before? 1, 2, 3, a couple. Who in here's had babies? Maybe more than one. Does anyone here know if they have diastasis recti? Does anyone in here know if they have diastasis recti that we could palpate? Oh, you guys have fixed it. Good job. Then I'll just have to give my little hand demonstration. So diastasis recti, if we were going to put somebody on the table, right? They're on the table. They're laying down. I'm going to put my hand anywhere in here, right? And I'm just going to sink my hand in. When they pick their head up, what you might feel, so here we are, sinking the hand in, right? If I have solid abs, she's not going to break past my abs, right? If I have diastasis recti, then what happens is this. And she'll have her fingers there, and when I lift my head up and my abs contract, the rectus abdominis is actually going to pull together and press against your fingers. And we measure diastasis recti, a 1 finger, a 2 finger, a 3 finger, a 4 finger, whatever, right? So that's diastasis recti. Postpartum mamas can't just go straight into planks. It's not appropriate. Physical therapy has the proper progressions, not TikTok, not Instagram. Physical therapy has the proper progressions for how to get yourself stronger and better without making this worse, because you can definitely make this worse. Yeah. Women and men that experience pelvic floor issues, it just carries with them, right? It's like a silent burden. These people probably, at least in the past, just have to deal with this for the remainder of their life, right? And stuff like that. So just so you know, as a PT, PTA, if you hear your patient talking about any of this kind of stuff, or if you happen to just say, you know, how are you feeling after your surgery? How are you feeling after your babies? Have you recovered well? Do you feel like you need some like therapy for that? Just, this is a silent burden, and people don't need to have pain with sex or inability to have sex or having problems after they've had a baby. Like, full recovery is expected, right? So just so you guys know about that and be a champion for that. Once in a while, you're going to hear something, I promise you. In the PT eval, we check everything, right? Subjective, objective. We're going to check the tone of the pelvic floor muscles. Is there scar tissue? Is there diastasis recti? What's going on in our global, like core and hips and everything like that. So we're checking everything. How are they doing with functional activities? When I lift my baby, I usually leak a little bit, you know, whatever the case may be. My business partner has a patient that just had a baby. She had the baby having never had penetrative sex. Was too painful, but she still managed to get pregnant. So there are actually, where's our little goodie bag? There are actually a variety of interventions that PT has. Will you see if you can find it for me? For anything and everything. So if it's pain with sex, women can get on a dilator protocol, right? Where you start off with this dilator, and over the course of weeks, you work into larger dilators. And of course, there's relaxation, there's couples therapy. There's like so many things that go into every aspect of pelvic floor physical therapy. We are not the ones that do everything, but we have some of the tools, right? So there's a dilator protocol, pelvic wand in the case of like pain and scar tissue and stuff like that. These are Kegel weights. Super fun, right? Lifting weights with your pelvic floor. And this is something else. You can look at it later. It's someone's too long or too big for sex. Okay. Yeah. I'm turning red, but this is real stuff, guys. This is like real life. You know what I mean? So common interventions. Let's just skip over this and let's get into our lab, because we have about 20 minutes and I want to use every little bit of it. So you guys can see some of what we're about to talk about here. Okay, so I'm going to talk about a case. While I'm doing that, if you guys could clear this table right here, and then Case, if you want to bring our camera over just to get a good view. Karen is actually going to show off some exercise. Yes, someone did? Someone does? Can we see it? Oh, please, please, can we see it? Okay, come. Okay, come. Thank you so much. Sacrificing your body, medical science. Will you? Yeah, you can lay on your back. Sorry, I'm just going to get out of the way. Hey, Case, just bring it like right there.
Oh, okay. So, for pelvic floor to assess CR on any patient, like Steve says, we do look into how many fingers we can fit in between the gap per se. We also look into how far my finger goes, and we count that about one knuckle, two knuckles, just depending on what we have. We can check 3 areas. We check right at the belly button, below the belly button, and above the belly button. So, before we start, I do want to start off with breathing. With all of my patients, I try to first have you engage that transverse abdominis here. I'm going to have you do, I'm going to have you go ahead and breathe in through your nose, like you're smelling some roses, and then I'm going to have you blow out through your mouth, like you're trying to flicker a candle. Good. Usually have them try it once or twice. This is the easy part. The harder part is whenever I try to have you engage here. So when you breathe in, I want you to push out your belly, kind of like you're pushing my hand away. And when you exhale, I want you to bring that belly button towards your spine and up, like you're zipping up. Good. Give me a little bit more. Good. And then relax. The point here, I don't want her to hold her breath at any point of my session because that's going to add more intra-abdominal pressure in here. So now we're going into the actual assessment. Okay, so I'm going to have you go ahead and breathe in through your nose, out through your mouth. I do want you to go ahead and lift your head a little bit whenever you exhale. Okay? So, I'm going to start. Good. Actually, don't have too much here. Go ahead and relax. So right here you have about 2 finger separation, and my knuckles didn't go in. Okay. So I would write that down. At the umbilicus, 2 fingers, no knuckles. I'm going to go below. Do you mind if I go ahead and just pull a little bit? Here, same thing, okay? Whenever you're ready. Same. You're about, you can go ahead and relax. You're about 1.5 fingers below the belly button, no knuckles. So I would write that on my note as well. One last one, right above your belly button. Same thing. Go ahead and relax. And right here, not even a finger. So I would write that on my note. She didn't have any knuckles and just 1 finger for her.
Will you show us transverse abdominis, isometrics, supine, side lying?
Yes, of course. So I'm going to have you go ahead and bend your knees. So now I'm going to ask her to hold while she's doing the exhale and keep it for about, you don't try to go for more than 3 seconds that first time around. This is a little more complicated for the patient. So I'm going to have you go ahead and do the same thing with inhale, exhale, and I just want you to brace the entire transverse abdominis, okay?
You guys try to do this with her. Like, make your tummy tight, suck your belly button to your spine, and breathe. Keep
Exhale,
breathing while
keep
you
your
keep
head
it tight.
Hold it for me. 1, 2, 3. And then you would release. And inhale again. Good. Exhale. 1, 2, 3. And inhale again. Good. So now I'm actually going to change our positions. We usually start in hook lying. However, this is not always the easiest for patients, so I like to change it up a little bit. I can go ahead and put you in.
Hook lying, the patient doesn't get as much feedback. If you put them on their side or on their hands and knees, you can actually see and feel more excursion as a PTA, even for the patient. And they are progressions, right? Supine, side lying, quadruped, those are progressions.
Same thing here. I'm going to have you go ahead and breathe in through your nose and out through your lips, but still trying to engage, okay? You might have my hands on you. I usually go ahead and make sure to place my hand right at their abdomen and one at the top just to feel their breathing, the inhale, that belly should come out, kind of like pushing my hand out. And with exhale, her belly should go back in. At the same time, I'm also listening to their breathing. Again, I don't want them to hold their breath while they're doing this, and I do this a couple of reps. I have some patients that find this easier, and I have others that find this a little bit harder to do. So I would have you do it. Maybe do 2 more times, just practice. Good. 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 I'm gonna have you in side lying now, okay? Hello. I'm usually in front, but just for the sake of it, I'll be right there. Do you mind if I put my hand on you again? Mm-hmm. And again. Oh, there it is. Perfect. Give me one more. Good.
These are all foundational, and you can add clams, leg lifts. If you're in quadruped, you can add a bunch of stuff onto that, right? So just so you recognize that. Yeah, and then the next thing, and this is not just for a postpartum woman who's having stress incontinence and diastasis recti, but a common theme in pelvic floor. Here's the diaphragm, here's the internal contents of the abdomen, and here's your pelvic floor. And this is more or less a closed pressure system. So the next thing we're going to talk about is if we're having like pelvic organ prolapse and some of these kind of problems and stress incontinence, one of the common things that gets talked about is managing this internal pressure. Imagine someone's chronically constipated, or they're an overeater, or they're very gaseous, or whatever, right? Like just too much internal pressure, right? Bloated abdomen and stuff like that. That can wreak havoc on the pelvic floor. And so Karen's going to mention just a couple of like internal pressure management techniques. Valsalva, we talked about that. Don't Valsalva.
Yeah. So same thing, like Steve said, I don't want them to increase that intra-abdominal pressure, especially for someone with prolapse. So what we try to teach them is exhale with exertion at any time. The same breathing I just taught you, we would teach them the same thing. And we would start them here. At times we would add more functional movements like a squat, or when you're in the bathroom, you're sitting in the toilet. A lot of patients tend to strain and hold their breath. That's exactly what we don't want with someone with prolapse. So again, a cue that we give them is, inhale and exhale through your lips like you're trying to fog a mirror while you're sitting there, and then keep repeating that. We also advise for it's called a squatty potty, just in case, so they're not straining themselves, because that pressure is very, very hard on the pelvic floor.
Diet, hydration,
Yes,
regular
very
exercise.
important.
There's a lot of different things that go into this, and you guys already know as PTs and PTAs, we have big conversations. Sometimes we'll be talking about diet and exercise, and sometimes even some like dipping into like psychological counseling. Not that that's our role, but we're the encouragers, we're the listeners,
Yes.
right? Patients like to dump on us, and it's good for us to be there for them.
Yes, definitely.
Okay. Next one is, okay, so there's a few stretches we're going to show for this one, but let's say there's a patient that is just newly married and sex hurts and it's awful. And this is why they're coming to pelvic floor. Their OB said, go talk to the crazy pelvic floor PT. They can help you with this. Okay? So there are some squats that are helpful. Counseling for the woman, perhaps couples counseling to arrive at a better understanding of how sex works and how the couple needs to interact to make this work better. That's something. And then, of course, education on like lubrication and maybe a dilator protocol. But here's some stretches that you guys might see for this and for some other things as well. But for this case study, that's what we're going to show it for.
Have you ever heard of a happy baby stretch?
I mean, I know that this is happy baby.
Yes. So this is one of the stretches we actually give to our patients for this particular case. Same thing. You'll hear me say this over and over again. The breathing is always in everything that we do. So just like I would tell a patient, so you would want to inhale. When you exhale, I want you to bring your legs up and over. If you can hold your toes, it's great.
Okay.
If you can't, we can always modify. You can hold on the side of your calf.
sometimes I demonstrate, so if you need demonstration, I can demonstrate it for you as well. But, okay, good. So, exhale whenever you bring them up. Usually have them hold for about 30 seconds. It's really important. This is supposed to be a stretch. So I don't want them to strain either. So if they can't hold at 30 seconds, we encourage them, I'd rather you bring the legs back down. I don't want to stress that pelvic floor more than it already is. So same thing, I'll have you inhale. When you exhale, bring those legs up, and you will just continue to breathe in through your nose, out through your mouth. Your way. Good. If you can bring it up a little bit wider. Yes. And I'll just have you breathe in through your nose, out through your mouth. Let's say the 30 seconds are up. Before you bring them down, I want you to inhale. When you exhale, lower your legs back down.
Oh.
Inhale through your nose. That's okay. And back down. And that's something really common too. You have to really remind the patients it's okay. The breathing takes time, but that's really important. It's a basic that we do have to get down, but we just talk you through it. So that's one of them.
Goblet squat.
Yes.
You want to just use this space right here?
Yes. Do you mind if I come over here?
She's going to do it without support, but you could use a TRX, like those little straps that stick into a door or that hook up to some gym equipment.
So I'm just going to have her do regular goblet squat. So yes, we watch for form and everything, but breathing. So I want you to inhale as you come down, belly still, pushing out. And when you come back up, I want you to exhale. Good. If I had a TRX, which is usually how we start them off, we'll have it here and we lower again with inhale and exhale.
Nice.
And that's really much better.
Do you mind continuing to be our little demo buddy?
Sure.
So next one is pelvic organ prolapse. Okay, you guys saw some pictures of some of those things. So for a patient with pelvic organ prolapse, pressure management's one of them. We talked about the internal intra-abdominal pressure, so we talked about pressure management, and then I'll let Karen cover the rest from there.
So same thing here. Everything just kind of moves on the same way. Breathing. Log roll. You guys are familiar with a log roll. A lot of our patients tend to just do this jerky move right off of a table. So I would just instruct the patient in that same way where I want you to go.
What happens with quick and jerky movements? What happens to intra-abdominal pressure with quick jerky movements?
Yes.
Right?
So
Is that a problem for organs that are hanging out or almost hanging out?
Yes.
Yeah. Oh yeah.
So I'm just going to have you come to your side. So it's a little bit. Good. Then you'll just scoot a little more to the edge of the table. Good. I want you to use your hands to push yourself back up, and you'll bring these legs down, okay? So nice and slow. Try to breathe through your motion. So inhale, exhale. Good. Something as simple as this, it sounds very simple, but the amount of patients that we see that just kind of stand up, especially with DR and any type of prolapse, it's very common. So we really work that into the session as well, especially with having like, we're just doing something on the table, like, okay, let's move on. They're very quick to just stand up, and we take that moment to be like, okay, let's educate you on, I don't want you doing this, because then they come back also not with prolapse, but with my back hurts or all of this. So it's time to educate the patient at that point.
That's the unspoken thing so far, is that with all pelvic floor problems, your core stability and control is impaired, which means back pain is very likely, sciatica is coming, your pelvic ring stability and balance may be off, so pubic symphysis dysfunction is on the table, SI dysfunction is on the table. For pelvic organ prolapse, I think historically, medically, they would do like some mesh interventions. Everything with mesh ever has turned out to be a bad idea, right? There's lawsuits you can see about on TV and problems with the mesh and stuff like that. So there are some medical interventions for pelvic organ prolapse to help. We won't get into those, but just so you know, they exist. Male pelvic pain, I think the takeaway here, and we're probably going to skip over this one to come to something more interesting, but males can have pelvic floor pain. They can have premature ejaculation. They can have problems like with sex, like a lot of different issues that guys can have, right? If they've had their prostate worked on, like prostate cancer and stuff like that, they can have issues. So this is a real problem for guys too. The guys that are brave enough to seek help for it, that's something else, because guys are just, you know how guys are, right? They're not going to be talking about this kind of stuff, probably just going to tough it out. But that's a real thing. So you come across a patient that's had some prostate work done or whatever, something like that, and you just perceive there might be something there. Maybe you can breach that conversation with the patient. Have you ever heard of pelvic floor PT? Are you having any problems with bowel bladder, pain, function? And if you're a female, don't want to breach that subject with the male, ask one of your people you work with, right, to maybe breach that or something. You know what I mean? Like there's different ways that it can be done. Pubic symphysis dysfunction. So we've got about 4 minutes left. Let's use it well. Thank you.
Yes, of course.
And thank you. If you would like to have one of these, you can. Thank you. Yeah. Okay. I'm guessing in this room there's at least one person that has experienced pubic symphysis dysfunction before, whether or not they knew about it. Has anyone here ever had a pubic symphysis dysfunction? I don't know. Has anyone here ever had pain in their groin, like an adductor spasm on one side? You have? Okay. So adductor spasm can come from either hip joint problem, thoracolumbar junction, or pubic symphysis dysfunction. The most common people to get a pubic symphysis dysfunction would be someone who's taking a lot of impact or force. So maybe you're just out walking in the park and there's a big hole and you don't see it. You step in it and a massive vertical force comes up into your hip and pelvis that can either shear your SI joint up into an upslip, or sometimes it'll shear the pubic symphysis. So pubic symphysis dysfunction is kind of weird because it will present with pain in here, adductor spasm, and the way that we would assess that would have a patient lay on their back. All right, dude, I need you to lay on your back, move your dragon out the way, and then I need you to put your hands on your pubic symphysis, okay? Put your hands on your pubic symphysis, and then me, the PT, or you, the PTA, can put my hands on top of his hands, and we're just gonna press. Do you feel any tenderness or pain on one side or the other? It should not be tender or painful. So if there is tenderness or pain on one side or the other, and I had a case study just last week, we palpated. Said, yes, that reproduces my pain on the right side. He was diagnosed with a sports hernia, but the imaging was negative. So how can you be diagnosed with a sports hernia if the imaging is negative? Tell me that one. So we palpated, yeah, that reproduces my pain, okay? And we ruled out the hip, we ruled out the lumbar spine, those things were fine, but his pubic symphysis was not only tender and painful, but if you actually palpate the superior aspect and the anterior aspect, you might feel that pubic symphysis is either superior on one side or it's more prominent on one side, okay? So now Casey's gonna come and demonstrate one of the interventions that we might do for pubic symphysis dysfunction, which is to pop that puppy. So watch this. So here's pubic symphysis, right? Okay? We have adductors that attach to pubic symphysis. So if I move the knees apart and I turn on those adductors really, really hard, it's going to pop, it's going to gap it. And hopefully when we gap it enough that the elasticity of those ligaments will help it to come back together in the right position. We do adductor isos and some different stretches and exercises. This guy that I saw was a climber, and he'd been struggling with this for months. He had done chiro, a lot of things. He had seen doctors and had the misdiagnosis. And I saw him and I said, this is what's going on. We're going to treat it. And he came back to the second session. He was like, I'm 90% better. And after a second session, I didn't see him again. He was done. So this is really cool.
All right. Karen, I'm going to use Karen because hers, we can typically get a good capitation out of hers. It's always kind of fun. So, kind of have some trust with the patient. You're going to have them lie supine. You're going to ask, do a small but short explanation of what they're going to do. Just don't come in and just start ripping and ripping. You want to give them a little bit of education. So I'm going to say you're going to lay down. If it's a pelvic floor lady and with everyone, you still want them to do the breathing stuff too. That can do nothing but help them, even if they're not a pelvic floor patient. I'm going to say, is it okay if I put my hands on you? I'm going to start putting my hands like this. Some people like to do here. I like to bring my whole forearm and wrist into it.
We're going to show both ways.
Yep.
Because I like that.
I'm going to be here. I'm going to tell Karen, I want you to squeeze into me as hard as you can. Just squeeze. Go, 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 go. Rest.
Get somebody else.
And then what we're going to do, we're going to come out, and she's going to push out. She's going to go out, out against me. Go.
It usually pops.
Go, usually pops. Sometimes you can try one more time each way. You can do it like this. She's going to push into me. Push, push. Nope. And then maybe like out. Go again one more time. Push.
You guys can switch.
Oh, okay. Karen usually pops right here.
How loud is it?
It's like a.
Everyone will hear it.
It's like a click.
It's like a click.
You have to push really hard. Sometimes if you're just doing a small adduction squeeze, you won't do it. So you do need to put more force into it. All right. Woo. Nope. Nope. Okay. We're gonna get someone today.
Yeah, we are. Switch one by one.
Okay, ready?
This is Steve's more than mine.
That was actually pretty good.
Yeah. When you sit at, it doesn't hurt. It's just an interesting feeling. Okay, so I don't want you to just because they go, oh, it's a different feeling. You're not really seeing with it. Think about when you talk about your neck, you're like a woo for a second, but there's no zing. Okay, it's a different feeling, especially if you haven't had it done before.
Okay.
Sometimes at the end, he added a little thrust.
Yeah. So wrapping up, and then that patient would go on to, we'd work on their back, their hip, we'd do some adductor stretches. They'd go home with some adductor isos and maybe some different exercises and stuff like that. The last one is not going to have a demonstration, but just so you know it exists. If somebody falls on their coccyx, or if they have a traumatic birthing process, their coccyx can become into dysfunction. There is actually statistically a most common coccyx dysfunction. I think it's side bent left and rotated left. I think that's the most common one by far. There are external things we can do to try to mobilize coccyxes and stuff like that. There are also internal things we can do. Any student that comes to me, I will tell them with a serious face on the first day that they have to do this to pass with me, but it's not true. They don't have to. So I was surprised to find this out. Physical therapists are the only people in Texas that can do this. Chiropractors cannot do this. Chiropractors cannot touch the coccyx in the state of Texas. I did not know. So anyways, if you ever talk to someone who's got coccyx pain and it's unresolved and they're sitting on that stupid little donut, you need to tell them you need to go see a pelvic floor physical therapist or an osteopath. Good luck finding an osteopath who's practicing osteopathic medicine, right? So that's going to wrap up for today. Thank you guys so much. If you guys will send out the pelvic floor vocab and the notes from today, and if you want to just have my email address inside of that, so you guys, if you guys are interested in the dry needling course, you'll have my email from Dr. Cox or Dr. Valencia. I also have a sign-up sheet here. If you're interested, you can do that. And I think we're going to be back in about a month's time to do some manual therapy, which is going to be all lab. I promise not to talk that much. It's going to be all lab. We'll learn some really good, like, soft